Hello, I'm Matthew Gavidia. Today on the MGH Life Sciences News Network, the American Journal of Managed Care is pleased to welcome Dr. James Wheless, Director of the Bonheur Comprehensive Epilepsy Program and Chief of the Department of Pediatric Neurology at the University of Tennessee Health Science Center. Can you just introduce yourself and tell us a little bit about your work?
Sure. Jim Wheless, glad to be here with everybody. I'm a pediatric neurologist. I've been involved in the niche of kind of looking at folks with epilepsy. Gosh, for over 30 years now, have been involved in that time over 140 research projects looking at ones that run the gamut from new treatments to new diagnostic techniques, but just trying to help improve the quality of life and improve our treatment for folks with epilepsy.
Amid the hysteria of the COVID-19 pandemic, mental health has become a major topic of discussion. Notably, increased levels of stress, anxiety, and depression nationwide can be caused by and contribute to impaired sleep. Can you discuss what implications this may have for patients with epilepsy adjusting to this new normal?
Yeah, so obviously for a lot of us, this has been a stressful last kind of 2-3 months. I think we've all hopefully are over the worst part of it, but still there, right? Haven't gone away for all of us, and especially for folks with chronic medical illnesses, and especially for folks with epilepsy, I would say. And probably unique to folks with epilepsy for a couple of reasons. We know that in general, if they are sleep deprived, so if they're not getting enough sleep, whether it's worry, anxiety, stress, whether that's about COVID or how do I get my medicines, going to the pharmacy, that can actually trigger seizures. So that's a little different from other medical illnesses. So it can actually cause them a health-related problem from it. And we know that certainly adolescents and adults with epilepsy are more prone to have, even before this, anxiety and mood disorders. And if you've kind of got a little bit of that at baseline where you're doing okay, and then you throw something like this on top of it, where your whole routine has been upended and a lot of our worlds were different, it can really ratchet that up. So we've been kind of, I guess what I would call, talking to our patients, kind of how do you, minimize anxiety kind of 101, which works for all of us, but especially for our patients, we've been very proactive. So we've been, from the get-go when this started saying, you got to have a routine. So I get it, you may be stuck at home and whether you're going to work or school or you're home from college, you got to have a routine. That's going to be key. So, get a time to get up, try and eat healthy, regular meals. If you can, depending on where you live, try and get out and, walk or do something during the day. Take your medicines on time, but keep that routine. Get to bed on time. That's really critical. This is a, minimal step to kind of just, make their overall stress kind of a little bit better.
How can neurologists optimally talk with patients with epilepsy on emotional health and sleep health?
Yeah, so great question. So luckily, when we were seeing patients even well before this started, and I think many of our colleagues, if they were coming back for a regular kind of epilepsy follow-up visit, we would ask about, the logical things, have you had any seizures, or you have any side effects from your medicine? Do you need medicine refills? But we knew even before all this that our patients were more at risk to have sleep problems, have mood disorders. So even before this, we were talking and regularly asking them, were you having any trouble falling asleep? Are you waking up at night? Trying to address those. And we were asking about things related to, mood and behavior. With this, it's in some ways almost been easier because, we could say, well, gosh, you're stuck at home now. Tell me about your routine. What's changed? And a lot of times the patients themselves would say, oh, yeah, it's been really tough being at home. I really feel stressed. So it almost like it was easier for them to bring it up in some ways, if you will. It made that conversation almost, more natural to be having at that time.
As emergency departments have become overcrowded and potential hotspots for COVID-19 infection, what significance can rescue medications have for patients, and how often are these medications needed for those with epilepsy?
Yeah, so our patients with epilepsy, obviously if they're well controlled, we want to keep them that way, but we have patients that have pretty good control, but once in a while their seizures uptick, they'll have a cluster of them or they'll have a flurry of them. And much like patients with asthma, we've kind of explained to our patients with epilepsy, they were on kind of baseline medicines to keep their kind of asthma under control, but most asthmatics will have an inhaler or something they can do, when things get worse. So something they can do at home and they don't have to go to the emergency room. Obviously, just like our asthma patients, if they get bad enough, there are times you have to go to the emergency room. So we're not saying don't ever go there, but if we can deal with it at home, It's usually better even before all of this started as well. So it's the same concept. The big difference is that historically we didn't have great options for our patients, whereas asthma patients did. So, we really didn't have good rescue treatments. So beginning at the end of last year and the beginning of this year, we've had two new rescue agents approved that are both intranasal treatments. And I may have, I forgot, I may have one. This is what they look like. So it's easy. You just hold up the nose. There's a button on the bottom. You push. It's inserted in the nose. It delivers the dose. So the patient does not have to be kind of with it. They could be in the middle of a seizure or between seizures and tired, or whether it's a spouse or a parent could do it. And there's two of those available now. One is an intranasal formulation of midazolam, and it's called a nasolam. And the other is an intranasal formulation of diazepam called Valtoco. But I think it's worth talking to the neurologist. Many neurologists, they're new enough and they came out at the front end of this, aren't aware of them because they're not getting out to meetings. They're not, maybe some of their office may be limited to who can come in. So they may not even know they're kind of out there yet. And for our patients, obviously in this time, we'd like to say, gosh, if we can treat you at home and not have you go to the emergency room, we're better off. Again, if they have to be there, but we'd really like to avoid that if we can.
Can you discuss some epilepsy action plans that have been designed for patients?
Yeah, so with our patients in general, again, even before this, we kind of covered things that would come up, that could cause their seizures to get worse. So, what if you have, a stomach problem, whether it's a stomach bug or something, you threw up your medicines, depending on which medicines you're on, what do you do as far as maybe redosing those or not redosing? So we cover that. We cover, kind of having a little bit of emergency supply of medicine, because what came up more was usually in winter months, for example. But what if there was a bad storm and, pharmacies were closed, you couldn't get out for a couple of days, you're close to the end of your prescription, keep a week or 10 days on hand so you can ride through that. With this, we've had a lot more people ask about getting their medicine by mail services. So a lot of folks had that option before, but weren't taking advantage of it. Now all of a sudden they kind of see the utility in that and say, gosh, I really want to get my medicines through the mail. So, we've kind of walked through that as well. And then another part of that's obviously things we talked about, getting adequate sleep and then having kind of a rescue plan. So, at what point, if your seizures have uptick, would you, give yourself or your loved one rescue therapy? And if that works, great. And if it doesn't, what's the next step? And then usually we're seeing them back, we're following up on that rescue plan just to review it and see, did you implement it? And if you did it work? Because if it worked, great, then we're set. We've got a plan that we know going forward we can use. If it didn't work quite as well as we want, if we need to tweak it or adjust it, that's the perfect time to do that. So hopefully going forward, we're better off.
What impact has telehealth use had for management of epilepsy? What feedback have patients provided from these online consultations?
So telehealth is something that probably every doctor in America was, a year ago, maybe 1% of us were doing it. Now we're all doing it. So I think it's been nice because it's, I don't know, I'd say it's a silver lining of the current epidemic, but it's one of the nice things that's happened because of it. Is that we really all got up to speed very quickly on telehealth, and not just the doctors, our patients too, because our patients didn't have that concept necessarily before either. So we've all kind of gotten more comfortable and figured this out together. But for a lot of our patients, it's been huge, the ability to connect with a doctor that they trust and know, just to touch base, even if they're doing good, just so that, they know, one, their doctor's still there, that they're doing okay, just that interface, just kind of help with that anxiety a little bit. We can get their medicine refills if they're doing good. And obviously for the people that need to get a hold of us, just to be able to do that as well too. So it really, I think, has been huge for a lot of patients. And as you might guess, there's a lot of folks that really have not wanted to get out at all. So just critical for them to be able to do it. I think going forward, once this is over, we've understood where it fits in better. I mean, there's some people that I just have to see in the office, whether it's, to examine them, their critical labs or diagnostic tests I can do at the office. But there are a lot of folks that we could do some of their visits by telehealth, and for a lot of them, just the convenience. I can, they could be at home, I could be in my office. We can do, a 20 or 30-minute visit, but they haven't, driven in an hour to get here. They haven't had to fight parking, get to the office, drive back home. So just, the convenience, and I get that for a lot of them, if we can accomplish the same thing by telehealth. is great, just beyond the kind of reassurance that it provides to them.
What further advancements in epilepsy management are still warranted to address factors related to this pandemic?
So I think that, the other things that will still come up related to this is, I still think the concept of kind of having some backup emergency medicines. Many of our patients who are in insurance plans that are just really tight. You're not due to get your refill to the end of the month, right? Within a few days. And I really think we've got to give the patients a little bit more latitude. And some have been better about that, saying, oh, we only used to allow 30-day refills. We'll give you 3 months now. So I think the insurance companies have responded, some of them in a positive way. I hope that continues, because our patients really need that. So I don't have that sense of anxiety about just their baseline medicines. I think that would be huge for our patients as well, to be able to do that. The other spinoff for a lot of our patients is some of the kind of diagnostic, just safety laboratory testing when you do, which is usually blood work. A lot of them really didn't know their local labs and have been surprised to find out, oh, there's a place really close by to me, I can get it done, and they can just, electronically send the results to Dr. Wheless. So I think, that's been a good thing. And if we can kind of keep up some of those relationships we've built with local providers for our patients from a distance, just the ability to kind of work together better to take care of our patients, I think that'll be huge too. If that same kind of motivation is still there as, things kind of calm down from this, that'll be a real plus as well.
And lastly, are there any topics that you want to address that have not yet talked about?
I think the other thing for, both patients and providers to keep in mind is, we've all, kind of been at home, and a lot of stuff has been put on hold, obviously, because of the COVID. Everything is COVID related. The news, everything is inappropriately so. But I think for our doctors out there, that means that many of them have not gone to medical meetings as they've been canceled. A lot of even non-COVID research has kind of been put on hold or shoved back. A lot of new advances some of the doctors are not aware of. So I think for the doctors, it's almost kind of making a point to say, gosh, I'm going to have to go to the virtual meeting because my live one got canceled, and because this is new stuff that's important for my patients that I take care of, that I need to know. And I think for kind of the research community going forward, we'll be playing kind of catch up this summer and fall and saying, okay, we've got stuff that we need to get back on track with to keep moving the needle forward with taking care of our patients with epilepsy and kind of advancing, the care that we can provide them and kind of the state of art in this area.
Thanks, Dr. Wheless.
Listen, great talking to you. Thanks, Matthew.
To learn more, visit our website at agmc.com. I'm Matthew Gavidia. Thanks for joining us.